let's talk about emergency. I'm head of the department, so I come sometimes on the emergency ward and not always. And it's mainly my colleague Hans Niebuhr who is managing the system. And this is a presentation we made together. So I think emergency needs speed. And if we look to the Revolution CT system, it gives us speed, rotation time, coverage, helical mode. We have a lot of speed in the system, and this covers then emergency. And why do we need speed? I think we don't want to have those kinds of patients long on our table. We need the diagnosis as fast as possible, and we need them to get to surgery as fast as possible. And if you see those things, it's not an artifact, it's just an image, and it happens. And I think the guy was thinking too much about speed. This was not his car, but I think he had another car. So another trauma case, pedestrian accident, and if we get a trauma case, a polytrauma, we want to go as fast as possible to get a diagnosis and to get those patients off the table for treatment. So we start with helical CT, and I say helical here, we shifted 3 times the last 6 months. We started with axial when we had first the system, then we shifted to helical, and now we are more convinced about axial, and we shifted again to axial. So the non-contrast non-CT at that time was a helical, but now we're doing it axial. And in that axial CT, we try to find bleeding zones. Here you see an hematoma, here you see bleeding. So, and then you get a coverage of the brain and what's happening there. And then we go over to a dynamic perfusion CT. And how do we manage this? We try to have in one scan as much information as possible. So we giving contrast, and this is just something we tried out now on the new system. We start with a bolus of 65 ml at 3 cc per second to fill all veins and organs. We wait for 25 seconds, and then we give a next bolus of 55 ml at 2 cc per second to have an arterial phase. And after that, we start the scan. So we will have a scan with a venous filling and an organ filling and an arterial filling. And we start a scan here, center of the skull, and we go down up to the legs, and sometimes we take the legs together. And in this way, we get nice images, we got a nice liver, we got a nice arterial phase, we got a nice spleen, lungs are okay, and bones are all okay. So quite fast, in 5 seconds, you get a coverage of everything, and you can manage your trauma patients and see everything which is necessary. We take SERV to 70%. I heard 50%, 30%, 90%, 70%, maybe something between all the others. And this is still under debate. In my opinion, we're still going up in a SERV. And we will end up maybe at 80, 85, 90, but we get used to those images, and we will have phantom data to be sure that we can go higher in a SERV. But now in those trauma patients, we take 70%, and I think everybody's convinced this is a good way of scanning. Do we need faster scans? This was a question I was asked for this morning. When we had the HD, I said, no, we don't need faster scans. It's more than fast enough. It takes only 10, 15 seconds to cover the whole body. Now we have this system, and I said again, no, we don't need faster scans. It's more than fast enough to cover the whole body. So probably faster scans will bring some new things and new possibilities. At this moment, I don't see a lot of possibilities in those polytrauma patients to still go faster. But probably there will be in the future. And then you can make all bone reconstructions, and we go for a large scan field of view, and still you see that bone reconstructions in the neck, thoracic and lumbar spine are quite good to go for immediately and good diagnosis. And then what you see in those patients, if you're going to scan them in a good way and look at images in a good way, you find often a lot of small fractures in all zones. And I think we're still missing some of those small fractures in those polytrauma patients. So scanning takes only 5 seconds. Going in a good way through all the images often takes 10 minutes, 15 minutes to write down everything which is broken and where you have problems. And the clinician is beside you, is behind you, and he wants an answer in 5 seconds. And I think this is a problem for us as radiologists. You get, in those 5 seconds imaging, you get more than 1,000 images. You get them in soft tissue, you get them in bone. Everything's coming out the machine. And still, we need the time to see and to look at all those images. And clinician thinks you scan 5 seconds, you make a report in 5 seconds, and it's okay, I will treat him. And my advice, certainly to the younger radiologists in my department, is take your time to view all the images. That 1 or 2 minutes, they won't matter. Don't try to give an answer in 5 seconds. It will be a wrong answer. The dose we give to those patients is acceptable. I think it's still quite high, but in those patients, I think we don't need to make compromises. We need to see everything, and dose is acceptable on this Revolution system. So speed is okay. Coverage, I think I showed also that coverage is okay already, but if you look to the system, helical mode 8 centimeters, axial mode 16 centimeters. And what's important for me is the easy switch from helical to axial. I think this brings something new, which makes different kinds of protocols possible. And I would like to show this for stroke. So we are a stroke center, and we get 3 to 4 stroke patients a day coming in, and they all get an axial plane CT. We switched again to axial now in the new settings. And on this axial plane CT, we try to see the bleeding. And we see the clot, sorry. When we see no bleeding, we start immediately with IV thrombolysis, like in all stroke centers. Door to needle time is now 40 minutes in our center. It should go lower, but it's not easy to tackle everything. The machine is on the emergency ward, so there we can go further. So if we see the clot and if we see no bleeding, we go for thrombolysis. And then we need to decide on thrombectomy. And this is something which is more difficult. Looking at a plane, at a CT without contrast and say, okay, there's no bleeding, do the thrombolysis. Everybody can do it, the younger assistants do it. But making decision about thrombectomy is something which asks more information, and at this moment, our younger people on the emergency ward during the night are not trained to make that decision in a good way. So they take the phone, they call everybody. And what we do to tackle this, first we did the perfusion CT. But perfusion CT is still quite complex. I think most of you know how to do it and know how to work with it. But the younger assistant during the night is not always able to do this in a good way. So we were looking for something else. And what we are doing now is we make a helical scan just for the morphology of all the vessels. And we add 4 axial scans in time, just doing brain imaging and vascular imaging. And those is really acceptable. It's a lot less than the perfusion CT. And you get a lot of information. You get all the morphology, which you get quite fast. And on those 4 scans, with the 5-second delay between each, 2-second delay between each axial scan, and 5 seconds between the helical and the start of those axial scans, you get a brain image and you get information. This is the morphological scan, the helical scan, where you see the occlusion of the internal carotid artery, and you see what's happening. And then this is the multiphase scan we add, and you get quite good information about the filling of the vessels. You see here on the right side, it's filling a little bit slower. And higher up, you see slower filling of the right hemisphere, cerebral media region, but you see the collateralization. And so I know a perfusion CT is better, but this is a quite easy one, and neurologists and radiologists from GARD decide based on these images to go for thrombectomy or not. And there we are also quite fast. Maybe after 10 minutes after the scan, it is decided if thrombectomy is needed or not, and if the angiographyst has to come to the hospital. So It's a complex machine. It gives a lot of opportunities, and sometimes we go more simple to make it workable. And then I would like to tackle another thing, radiation dose, iodine dose. New machines scan faster, and so you can give a lot more radiation. And we all know that younger people, okay, they can have some iodine loads, but watch out with radiation. And elderly people, okay, they can have some radiation dose, but watch out with iodine. And I would like to tackle the example of the pulmonary artery CT. So what makes a good pulmonary artery CT to exclude pulmonary embolism? You need speed, mainly to reduce breathing artifacts. You need contrast detail. You need spatial detail, also to exclude other pathology. Here again, this is our protocol. We go for a noise index of 25, which is quite high. We go for the 8 centimeters helical. I agree, axial could have some advantages, but I think it's easy to go for helical because all those patients, breathing is often a problem and they can't stop breathing. So in the emergency wards, we say, okay, we go for helical. We take large body and we go for SERV 70%. And we do the scans with 35 ml of contrast. With the HD, we use 70 ml of contrast. So we reduced it by half. So I think the Revolution system makes it possible to go for a lower dose, for lower iodine load, and still have really good images.